Hello, everybody. Good morning to you. Good afternoon. Good evening. I'm delighted to welcome so many of you from all over the world to this first ADI webinar of the new year. As we start, please let me share an incredible figure with you. So our registrations for today are 2,186. It's so wonderful to see so many people joining us for this really pretty important topic. As well as those joining us for the live stream, lots of people will be watching this recording on YouTube in different time zones that are not currently conducive. Although one of our panelists today, Professor Yun-Hee Jeon, is joining us at midnight from Australia. Yun-Hee, thank you so much for staying up so late to do this. I do hope you've got a big cup of coffee on your desk. So next slide, please, Megan. So I am Chris Lynch. I'm the Deputy CEO of ADI and the Director of Policy and Communications. Before joining Paola and this incredible team at ADI, I worked at Alzheimer Scotland, which is an ADI member association. And you'll see from our lineup today, it's so nice to have one of the Alzheimer Scotland team join us as a speaker as well, Professor Elaine Hunter. I'd like to say a big thank you to the ADI team supporting this webinar behind the scenes, especially Megan, our Senior Events Manager, and Robbie and Hannah in communication. And also a call out to Hannah's mum, who is currently in Canada at breakfast time, joining us online today, along with our chair, Dale Goldhawk. So you'll see from the slide, I was supposed to be co-hosting today's webinar with a wonderful colleague, Dr. Katrine Seher from the WHO Brain Health team. Now, unfortunately, Katrine has been called away at the last minute on member state business. But we do have a number of the WHO team from Geneva online with us today. Obviously, one of our presenters as well, Dr. Alexandra Rauch, but also Laura and Primrose. They'll be in the chat area, so please introduce yourself to them and engage them as well. And on that note, please do say hello to each other as well in the chat area. And in the chat functionality, because it is an open webinar, we do want to hear questions from you as our panelists come to the end of their presentation. So please use the Q&A area for that. And next slide, please. So we're going to run a quick poll today just to see who has joined us. Megan, if you could run that poll for us just now, that would be wonderful. Give everyone a few minutes to complete the poll. It's really interesting to see what the mix will be today, especially because we've got such a large audience. I think Rehab particularly is completely rooted in post-diagnostic support, which we featured heavily in the World Alzheimer Report in 2022, but really hoping today gives us an ability to drill in. So interested to see who's joining us from health, from care, from the associations. Megan, are we about there with the results, do you think? Real mix, but not unsurprisingly, educator and medical professionals are very, very well represented there. Super to see you all online. And if we move to the next slide, please. Let me just tell you a little bit about ADI for those of you who are not overly familiar with us. So we were established in 1984. We've currently got 105 member associations around the world, and we've got 20 more in our membership development program as well. And we represent our members at the WHO, the UN, OECD, lots of other multilateral and regional bodies as well. And you probably know us best for our World Alzheimer Report and World Alzheimer's Month, of which we are the champions. And the next slide, please. So how did this webinar come about? Well, as you know, ADI is in official relations with the WHO and the UN, and it's part of our work plan that we identified with the team in Geneva because it's such an important area and such an important part of post-diagnostic support. So we wanted to really bring this to the fore. And next slide, please. Again, just a call out. ADI is a not-for-profit organization, and we're only able to do what we do by raising funds. If you are able to donate, please do help us to do so. Next slide, please. So it's purposeful, really, that at the start of this year, with a webinar focusing on rehabilitation, as you'll see from this slide, we will continue the focus on rehabilitation throughout the year, culminating in September with the World Alzheimer Report on rehabilitation. Now, the team that is behind that is on the call on the webinar today. We've got Wendy Wiedner, who's our Research and Publications Director, and Chloe Benoist, our Publications Manager. They're going to identify themselves in the chat for you, so please do connect with them. And obviously one of our speakers as well, Professor Yun-Hee Jeon. She's part of the combined university team of Sydney and Essex commissioned to deliver this report. Call to action for us, I think, whilst we have everybody's attention on this webinar, is that we're putting out a call for information on actual dementia-specific rehab services that are routinely offered, that could be inspirational, that we could make case studies of. If that applies to your work, please do get in touch. And let me set the scene if I can before I introduce our speakers. So I pondered on this question of rehabilitation and why we were doing this webinar with WHO. And people with dementia are not routinely offered rehab, despite really experiencing disability associated with the condition, and despite accumulating evidence for therapies such as exercise, occupational therapy, and cognitive or physical rehabilitation. However, people invariably have to seek out rehabilitation support and services. Just repeat that. People have to seek it out. So, as we move through today's webinar, let me pose a couple of questions. How do we change that so that rehab and the benefits of rehab are proactively considered and offered as health, care, and community supports? And an overarching question, do we think that the lack of proactive offering of rehabilitation is tied into societal perceptions about dementia, which maybe relates directly to our World Alzheimer Report last year? And next slide, please. So at this stage, I'm absolutely delighted to introduce you to our speakers. Katrine was going to do this for us, but I've asked each of our presenters if they would give you a quick introduction themselves as we go. But we have Dr. Alexandra Rauch from the WHO, Professor Yun-Hee Jeon, University of Sydney, Dr. Jennifer Bute, advocate and currently living with dementia, and Professor Elaine Hunter, National Allied Health Professions Consultant at Alzheimer Scotland. So at this point, I'm going to pass over and we're going to start these short presentations before we move into the Q&A session. And at this stage, Alexandra, could you please introduce yourself and your presentation? Thank you.
Of course. Thank you, Chris. Thank you so much for your fantastic introduction to the webinar and the topic, which is absolutely important. But I really want to thank Alzheimer's Disease International to offer this platform for this webinar on this so important topic. And as we have discussed, we consider this a bit as the starting point on a rehabilitation on dementia year, as you have already introduced with the launch of the report on rehabilitation, which will upcome in September. Who am I? So my professional background, I am a physiotherapist and a health scientist. I worked in practice of physiotherapy. I worked as a teacher, professor in physiotherapy, did research. But since 2018, I was lucky to work with WHO Rehabilitation Program on the Rehabilitation 2030 initiative, which has the goal to allow, or the vision that all people in need have access to rehabilitation. And this is a great opportunity. It's fantastic to see so many people globally who share this vision and who work with us on this same vision. Now, my talk today is about rehabilitation and dementia in the global perspective. I want to start with what is rehabilitation? And I start with a bit of a technical term, a definition provided by WHO, saying that rehabilitation is a set of interventions that aims to optimize functioning and reduce disability in individuals with health conditions. This is important because in the area of dementia, oftentimes other terms are being used, such as reablement, functioning-focused care, or restorative care. It's important. All these terms have the same target: to improve functioning in people living with dementia. And what does this mean? So it helps, rehabilitation helps, that people can become or maintain as independent as possible in their everyday activities as long as possible, but also to enable them to participate in meaningful life roles such as work, education, interpersonal interactions, and other important life tasks. And therefore, rehabilitation offers a range of therapies and interventions that are evidence-based and useful to people in need for rehabilitation. So why rehabilitation matters to people with dementia? Of course, dementia causes impairments in the brain. And there are many approaches to prevent dementia. We know a lot about this, to prevent dementia and also to treat. But until now, unfortunately, it is not possible to cure rehabilitation. And so, therefore, we need to ask, what does it mean to people living with dementia? So it means that they may face problems in communication, in moving around, in being independent in their daily activities and self-care, in going to work, in interacting with others, and also to such things like a play or recreational activities. And this is what we call functioning, and this is where essential and evidence-based interventions for rehabilitation are available. From a WHO perspective, it is so important to keep in mind that rehabilitation is considered one of the essential health services to which all people in need should have access to without the need to pay out of pocket. And we all know this is not the case. There is a broad variety across the globe where people don't have access at all, or only if they have the money to pay out of pocket, or it's funded by insurance systems or other ways. That is important when you think about the need. And the need is huge. And you can see in 2021, it was about 58 million people globally who would have benefited from rehabilitation. And when we look back to 1990, you can see the increase. It's more than doubled. 58 million people who could have benefited from rehabilitation. I want to put this a little bit in context and compare with stroke for two reasons. The one thing, as you can see, dementia is nowadays the prevalence or the number of people who would benefit from rehabilitation is nowadays bigger than the numbers suffering from stroke. That was differently in the 1990s. And we all know with aging populations, this will still increase, and also probably due to better treatment for stroke. But we need to be aware more and more people will need rehabilitation. The other thing is the understanding of rehabilitation. I assume that when we talk about stroke rehabilitation, for many people this is clear. Yes, of course, a person with stroke needs rehabilitation. And maybe this is because still there is the understanding that rehabilitation is primarily to improve physical functions. In many countries, people still think, well, that's probably physiotherapy. Of course, yes, but physiotherapy is only a part of comprehensive rehabilitation. But it also includes to have speech and language therapy, occupational therapy, and of course, so important, psychological therapies. And here is where probably the awareness is very different, where many people, even service providers and consumers by themselves, do not know that they can benefit from rehabilitation. Now, what is the WHO response? They're different. I just selected three. First, there is the Global Action Plan. Importantly, this has a section that makes recommendations to improve dementia diagnosis, treatment, care, and support. And importantly, as you can see, this runs out 2025, but it's already on the agenda of this year's executive board to discuss to extend it for another couple of years. And this really would help to focus more on any interventions relevant to people with dementia. Another important landmark was 2023, where member states signed a resolution that calls member states and stakeholder organizations and WHO to expand and integrate rehabilitation in health systems as part of UHC so that everyone has access to it. And where I will go into a little bit more detail is a package of interventions for rehabilitation that was also launched in 2023 that provides a list of essential evidence-based interventions for rehabilitation in dementia. Now, this is a resource, and I'm very happy that the next speaker is going to be Yun-Hee, who was one of the drivers in this working group to develop this package. And she also did a lot of literature searches to identify the evidence on those interventions. And this review has informed the selection of the interventions. And this was also done by experts from around the world to select those interventions that are really beneficial to people with dementia, with a specific focus on the low and middle resource context. Don't worry, I will not go to this list. It's a long list. Just to summarize, this package shows that there are evidence-based effective interventions to improve or maintain mental cognitive functions, to improve or maintain speech, language, and communication, swallowing, to improve and maintain motor functions, mobility, exercise, and fitness, to improve and maintain the independence in daily living, as well as interpersonal relationship. And I would say most importantly, it also includes interventions that targets the carers and their families, because we know they have a huge burden in the care of people living with dementia. Who are the main target users of this package? From a WHO perspective, as you may know, we of course mainly work with countries, with ministries of health. So our main target users are the ministries of health, and the package can help to countries to develop their own health benefit packages to be integrated into the health systems, or to develop national clinical practice guidelines for rehabilitation on dementia. But as you can see, the list is longer. So many other users can use this package, such as those who provide the care, service planners and service providers, to make sure at their settings that they provide those interventions that are evidence-based and essential. I think a very important target group are those responsible for the workforce. We know until now in many countries the rehabilitation workforce needs more attention, it needs more people, and it needs more professions such as speech and language therapists, occupational therapists. So also they can use this information to train the service providers, the workforce members, to gain the competences to deliver these interventions. Rehabilitation research is also another important topic because we need more high-quality clinical practice guidelines for rehabilitation in dementia. But as you can see, I added another topic that is about advocacy. I think we are still at a level where we need to do more awareness raising, more advocacy to really let people know what is rehabilitation in dementia and why is it so important that it is accessible to people and their families and carers. And this targets all the stakeholders, organizations, and I can assume many of you are in the call today, such as consumer organizations, professional organizations. So please use this resource and share this with whomever you think it is important. I am looking very much forward to your questions that we will have the opportunity to end, but here I stop because we have this fantastic panel that also has very important information to share. Thank you for your attention.
Alexandra, that was absolutely wonderful. Thank you. Thank you so much for it. Your figures on the eligible population, the numbers of people that effectively have missed out on rehabilitation support are absolutely incredible, but really underpin why we're doing this as well, to make sure that that picture changes in the future. So thank you for that. Great, great intervention. And at this point, you have teed me up very nicely. So I'm going to pass over to Professor Yun-Hee Jeon, who you've already mentioned for me.
All right. I've just realized I was on mute. Hello, everyone. I'm Yun-Hee from Sydney, Australia. I'm professor of healthy aging from the University of Sydney. And I have nursing background. I've spent the last 25 years or so working with clinicians, care workers, people living with dementia, and care partners, as well as industry partners and stakeholders, the service providers in developing and building evidence of models of care for people living with dementia, and particular focus on rehabilitation and reablement. My presentation today is going to be very much around practical aspects of rehabilitation. Before I go ahead start, I want to thank you, the Alzheimer's Disease International, for this wonderful opportunity to share my thoughts and ideas around rehabilitation. I feel very much privileged. Now, let me start with the concept of healthy aging, as it's very much aligned with the definition of rehabilitation, where the focus is on the functional ability, which is about not just the physical ability and physical functions, such as moving around, but also building and maintaining relationships, meeting basic needs, learning, growing, and making decisions and contributing. As shown in this figure, the functional ability is explained by the fit between the person's intrinsic capacity and also their environments. And the environments include their social, societal, built environments, climates, and cultural environments. So when you look at this notion of healthy aging, it really highlights the need for holistic approach in rehabilitation. The uniqueness of rehabilitation is that rehabilitation provides a structure, methods, and strategies for healthy aging, as well as ways to monitor and evaluate the overall success of healthy aging, in my view. Now, let me talk about some universal principles. Rehabilitation, regardless of health conditions or disability, or the types, can be an approach to care philosophy, specific intervention, program, or model of care, also known as a service, that can be offered in all care settings, not just in rehab centers. It can be self-initiated and or supported by family, care partner, care workers, and healthcare professionals. It's really important that personhood and individualization is respected. It's primarily focused on function and independence, and it therefore calls for holistic approach. Now, whilst the individual's disability or impairment remains to be an issue, they can exercise an optimal level of autonomy and control over their daily activities through rehabilitation. And this is something that we need to remind ourselves, having sense of autonomy and control, and they are extremely important part of independence. Now, when we talk about rehabilitation in the context of dementia care, additional considerations must be made. Their cognitive health, which is likely to decline as the condition progresses further, types of dementia and severity need to be taken into account. We know that dementia is not a single disease. Some people find communicating with their thoughts with others quite difficult. Some have difficulties with memory, others find making decisions challenging, or a combination of all, for example. Dementia is more prevalent as people age, which means frailty and multiple chronic conditions are likely to coexist and further decline. We also know dementia affects the person's behavior and emotional function. Therefore, effective rehabilitation needs to multidisciplinary team approaches and ideally interdisciplinary team approach to address those issues together. The person's motivation and communication styles need to be considered, and working with a care partner is much more needed, whether they are paid care workers or non-paid carers. Key steps in rehabilitative care. The utmost important starting point is understanding the person, knowing the person, their interests, ability, preferences, strengths, and limitations, their medical, psychosocial, environmental context, motivations, their readiness to change. Those things need to be understood by practitioners who are providing rehabilitative care. Collaboration is another key. The goal settings, their personal goals, individualized strategies and interventions together, and supporting that. So rehabilitation isn't about the expert clinician providing information and providing the prescription for the person to practice. It is all about collaborating. So you may remember earlier Alexandra's presentation about various types of interventions that are evidence-based. What's really important is that setting goals and strategies or selecting interventions must be individually appropriately tailored. And therefore, it is really important that we understand that just because cognitive training or cognitive stimulation therapy is evidence-based, it doesn't mean that it should be applicable to everyone or it should be the main priority for everyone. This is where the importance of that comprehensive assessment comes in. It's also important that we continue to monitor goals, achievement, and strategies, and revisiting and reestablishing goals and strategies. And evaluation is also an important part of rehabilitation. We need to understand what the next steps could be based on the success or unsuccessful outcomes of goals and strategies. We also need to be mindful about establishing achievable goals. And it isn't about the person suddenly being able to walk around the block within a week. Our study participants talk about often the small changes. And one carer in our program said the most important aspect of rehabilitation that she learned was that incremental changes that made a dramatic difference to the father that she cared for. Now, this is a slide that provides an example of a model or rehab program we call interdisciplinary home-based reablement program. And it's led by occupational therapists and registered nurses together and bringing other allied health professionals as needed. But it provides the very much important comprehensive assessment and along with the other smorgasbord of options. And this type of model or program is quite useful because it provides a structure and also it provides opportunity for teamwork that is much needed in dementia rehabilitation. Of course, this is just one example. There are many studies and major trials that demonstrate the effectiveness of rehabilitation program. And we also know that those programs not only improving individuals' function, but also quality of life in some studies, and also carers' well-being as well. We also learned that from our systematic review of clinical quality guidelines, that there are over 280 interventions and assessments that are evidence that have a strong, reasonable evidence to be used. We also reviewed programs, dementia-specific programs that also showed effectiveness. Let me quickly bring your attention to then how is dementia rehabilitation is addressed in Australia. I guess we hear a lot about reablement and restorative care in general, especially in the context of in-home or community aged care. And yet the term rehabilitation is predominantly used in healthcare, subacute care settings, as if rehabilitation is not applicable to those in aged care settings. We also see an emphasis on reablement in various policy and regulatory documents, such as aged care standards and the recommendations from the Royal Commission into aged care quality and safety. Whilst all those terms are intended for improving the person's independence, there has been a great deal of inconsistencies in how they authentically apply the principles of rehabilitation mentioned earlier. Importantly, most of the existing programs and services for reablement restorative care fall short of sufficiently trained staff and resources required when they are offered to people living with dementia. In the recently released National Dementia Action Plan, Action 5 stipulates that the government plans to identify, develop, and promote early intervention, reablement approaches, restorative care supports, and resources people with mild cognitive impairment and dementia. It is important that the plan goes a step further, that cements reablement restorative care rehabilitation as a part of routine practice. What about dementia rehabilitation in other countries? This limited access to appropriate rehabilitation programs or services that are specifically designed for people living with dementia is not a unique feature in Australia. As you can see from this table that I review post-diagnostic dementia care in the Western Pacific region, show that this is an issue across all 6 low, middle, and high-income countries. Recently, a group of us from 5 different countries, Netherlands, Denmark, UK, Sweden, Australia, developed a policy brief on reablement. The brief is based on the latest research evidence and expert views on reablement in policy and practice. During this collaborative work, we further confirmed that rehabilitation, whether we call reablement or restorative care, is generally not accessible to people living with dementia. And this is the policy brief that we developed. The key areas that we really emphasize in this brief include public education and stigma reduction. It is a really important part of the solution. Workforce training and education, and policy and system level changes and models of care. Now, these aspects are really important to be further tested through implementation research. In summary, we see advanced knowledge in the role of rehabilitation in dementia care and how it can be implemented in practice. We also see a growing attention from governments and policymakers about rehabilitation in dementia care. We also know timely rehabilitation offers hope and confidence of those people living with dementia. But there is a major gap in knowledge and practice. Rehabilitation is still not front and center in dementia care. We should not accept this status quo. And when I hear rehabilitation in dementia care, I see hope for the present and the future. And we really hope to see this becoming front and center of our dementia care. Thank you.
Yun-Hee, thank you so much. Your ending there resonates very strongly, and I think takes us right back to me pondering on this subject at the very beginning when we first started talking about this, is why is the burden on the individual to seek out rehabilitation? And how do we turn that around? wearing my policy hat for a moment as well, I think the real opportunity here in policy space sits with disability. And I think we should follow this webinar up with some discussion around that particular area as well. But let me pass over the floor and the microphone to Dr. Jennifer Bute, who have been the privilege to work with over the last 7 or 8 years. Jennifer, please give us your thoughts on the benefits of rehabilitation from the consumer perspective. Thank you.
Thank you. I'm a medical doctor, a GP, I was, in family medicine in the UK, very much involved in the past with medical education for doctors and nurses and students. But I had to take early retirement because I was diagnosed with early onset dementia. So slide 1, please. And I've been asked to talk about my Japanese memory groups as a form of rehabilitation, because I remember when the word rehabilitation started to be used, as I had always been using the words cognitive stimulation in enabling one to stay well with dementia in the context of social engagement, where it's just part of rehabilitation. I first started my Japanese memory groups in May 2012. I had been in London giving a lecture on dementia, and Professor Kawashima was also there giving a lecture. I was amazed as he showed videos of people with dementia in Japan. A lady lying in bed, unable to feed herself, being made every day to draw circles in the air. Being able to, being able to draw circles in the air with her finger. That's writing. To recognise her name. That's reading. And 1 and 1 make 2. That's arithmetic. And how eventually she was able to sit up in a chair and feed herself. Also a very disruptive lady with dementia made to join in such daily activities, becoming cooperative and pleasant. He was really just getting everyone to do reading, writing and arithmetic without realising. That is how we were wired up as children to start learning at school. So our brain thinks reading, writing, arithmetic, new neuronal connections needed as learning is required. And I have 3 principles in dementia. There's always a reason for what someone says or the way they behave. Secondly, feelings remain when facts are forgotten. That's so important. And thirdly, patterns continue. For example, the pattern of how our brains learnt things as a child. So I thought, why aren't we doing that in the UK? So I started with groups with materials written for children when first starting at school. There were about 10 people in the group, and they were rightly insulted. They were not 5-year-olds. So I had to write happily my own materials, all containing fun activities using reading, writing and arithmetic. And I called the groups Japanese memory groups after the Japanese professor I mentioned earlier, who gave me the idea without realising. And I wrote a series of booklets based on each letter of the alphabet. And I was later asked by an organisation who had seen these to write another series on food to go with their resources, also using the alphabet, which I did. And I started by holding groups twice a week, which worked well. I think we're on slide 2 now. The initial small group grew rapidly to about 30 people. I had to stop people coming in from the locality, as we'd been on television quite a lot, so our fame had spread. Memory scores improved for those coming to the groups. Relatives were amazed, and we all had such fun. So what did we do? This picture shows some of the people sitting in groups of 6 to 8, working through their booklets in pairs. It was not a competition, it was not a race or an exam paper. They just did as much or as little as they wanted. and every booklet each time contained activities involving reading, writing, and arithmetic. We met for 30 minutes, providing the pencils and crayons, sometimes even small rewards given to everyone for effort, not scores. We always started with music, which is so important in dementia. Then singing a familiar song, the words would be in the booklets. Then reading a familiar poem together, aloud. The activities had no right or wrong answers. No one could fail. And participants had constant affirmation. I was amazed to see those with advanced dementia reading or even reciting familiar poems aloud. Their husbands were astonished. And even others that were thought to be mute, starting to talk. The social interaction had made such a difference as well. Slide 3, please. You can see one of our booklets page on food, beginning with B. All the food began with B. And underneath the pictures of the fruit and vegetables are listed 5 possible tasks. That's reading. And one of the tasks was to circle any group of 3. So that's writing and arithmetic, underneath the fruit and vegetables. And the booklet below that, you can see it shows the simple maths. Very simple. But the answers were never marked as right or wrong. Slide 4. We always did something with coloured shapes. Where does the blue triangle go? If only one of each shape is allowed across or down the page. And even those with advanced dementia could do it. For them, we made separate large cards and cut out coloured shapes so they could try out possibility. Perhaps I should add, I lived in a community with about 80 people with dementia, about 20 had a really advanced dementia, really, really advanced. And then those who were just suffering with some with Parkinson's and stroke and things like that. Slide 5, please. So all individually helped. But as you can see from the picture, just giving the man more ladders to help him look over the wall was useless, as he didn't know what to do with them. We needed to always show each person how to show the booklets and all it contained. Slide 6. People started arriving early, so I had activities for them to do before the proper session started. Aqua paints were white blank cards, which, if brushed with water, would show a coloured picture. The men particularly liked those because we'd have cars and mail things on them. We also played double games, which was a kind of snap, with the same items on circular cards for them to spot. You can see the 3 there. It's clear there that the red circle is in all of them. Another game was names of familiar places, or well-known sayings or proverbs, cut in half, and finding the halves that matched was the task. We had great fun with that. And we used the same booklets each year, newly printed, of course, because no one remembered having used them before. These groups made such a difference to everyone. All enjoyed them within a warm social environment. They all left with smiles and a feeling of achievement and accomplishment, were reassured and restored, strengthening them in former abilities, rehabilitation. Just as after a stroke, we expect improvement with activities and health. So why not with dementia?
Jennifer, I think that brings us to the end of your slides. Thank you so much for that. It's incredible to see this in practice, and it's going to link me up extremely well to Professor Elaine Hunter, because her focus is about integrating rehabilitation for people with dementia into practice, perhaps the NHS level. Just a quick thought though, because I can see an incredible amount of activity in chat and the Q&A. There's a couple of really, really good questions in there about the applicability for lower and middle income countries. I see Alexandra's already picked a few of those up and replied in writing. I think one from Geeta, Dorky, and Mauritius. There's a couple more in there as well. So, Alexandra, if I could call on you to answer those as well, that would be absolutely superb. Thank you. Jennifer, thanks again. And I am now going to pass over to an ex-colleague and a good friend, Professor Elaine Hunter from Scotland. Elaine, the floor is yours.
Thank you. I'm delighted to be here. I'm Elaine Hunter. I'm National Allied Health Professional at Alzheimer Scotland. I'm an occupational therapist by background, working more recently in an HP leadership position, but I've been working clinically and in practice as a clinical leader in practice for over 40 years now, so delighted to be here today. The work I'm sharing with you is hosted in Alzheimer Scotland and commissioned by Scottish Government, and I'm adding another perspective to this webinar, and I'm going to consider how do we apply the evidence that we've heard about today in everyday practice, and this is our experience in Scotland. Next slide, Megan. Thank you. To put my work into perspective, it's important to be aware Scotland has a population of 5.5 million and health and social care is devolved to Scottish Government. To apply the research evidence on rehabilitation, I believe national and local context is key, and I'm going to start there. Alzheimer Scotland is Scotland's leading dementia charity, and proud of the work to make sure nobody faces dementia alone. Campaigning for change by developing evidence and rights-based policy informed by the voice of lived experience, and some of them you can see on the slide there. Next slide, please. We also have policies in Scotland with ambition for rehabilitation to be integral to how we deliver services. Rehabilitation and recovery presents a once for Scotland approach, ensuring rehabilitation is personalised and outcome focused. The new dementia strategy for Scotland is a 10-year vision for change and integrates rehabilitation as a support option after a diagnosis of dementia. And last year, we launched our third Allied Health Profession Dementia Framework, Connecting People, Connecting Support, that I wrote but in partnership, and that leads and informs the work I'm going to share with you today. Next slide, please. In Connecting People, Connecting Support, which we originally published in 2017, we defined an evidence-based AHP approach that is underpinned by human rights principles and is a well-recognised model in Scotland and in the UK now. In the third report, I acknowledge there's a rehabilitation gap that must be filled, that we need to increase awareness of what dementia rehabilitation is and how it can add value to lived experience and add value to services, and apply the evidence of dementia rehabilitation in practice we've heard today. And on the slide is who's included in allied health professions in Scotland. I'm now going to share with you what we've developed so far over the past 10 years in Scotland. Next slide, please. To integrate the rehabilitation evidence that we've heard about in practice, we've adapted and designed a delivery model that you can see on this slide. The terminology of universal, targeted and individualised or specialist is familiar to allied health professions across the United Kingdom. This whole system, seamless approach provides a platform from which allied health profession services can respond to what people live with dementia and their families are asking for now and in the future. Next slide, please. Universal and targeted interventions you can see on the slide just now. We've developed these resources exploring digital opportunities to increase access to evidence-based AHP-led self-management resources, while also evaluating outcomes and impact with over 100 resources available on one website at Alzheimer Scotland. Print-out versions are also available that we know are being shared in local communities. All the resources are free, and the links I've included on the slide there that you can access Alzheimer Scotland AHP resources. Next slide, please. To illustrate individualised HP dementia rehabilitation, so at the other end, at the specialist individualised, I'm sharing just 2 examples of what we've integrated into local NHS services in Scotland. Both are a post-diagnostic intervention. The first is our occupational therapy home-based memory rehabilitation, which is a cognitive rehabilitation approach that takes place in the person's homes. And you can see a few of the quotes of the impact it's made to the person living with dementia, their family carer, and the occupational therapist delivering this intervention. And we have also been implementing Journeying Through Dementia, which is an occupation-based peer-to-peer group that takes place in a local community. And again, you can see the impact that this has had to people with lived experience. Both these rehabilitation interventions are evidence-based. They're co-designed with people living with dementia and also their practitioners, and we implement them using an improvement methodology supported, importantly, by a measurement framework. Are we doing what we intend to do with these interventions? Next slide, please. Training and education of the current and future health and social care workforce is key. We began this work in 2014, developing allied health profession student placements and academic internships between local universities in Scotland and Alzheimer Scotland. We've published a number of evaluation reports that you can easily all get access to on this work, that's on this slide. We've completed a recent scoping report with our 7 higher education institutions in Scotland that offer our HP pre-registration programmes, outlining how they cover and what their education programme involves around dementia care. And we recently published a textbook, which we're very proud of as well. And next slide, please. None of the work I've shared with you today would be possible without a co-design and collaborative approach. It's the work of many innovative and dedicated people, including people with lived experience, our researchers, clinicians and practitioners. We have a national Alzheimer Scotland HP Dementia Forum who lead the local delivery of universal targeted and individualised rehabilitation in the local services. Next slide, please. And finally, the work we've developed in Scotland has and will continue to be guided, challenged and informed by the voice of lived experience. I have the privilege to work with both the Scottish Dementia Working Group and the National Dementia Carers Action Network. Recently, a couple of years ago, my colleague captured a conversation with Henry, Lorna, Ian and Margaret, who were talking about rehabilitation and dementia. And Ian says, when you're talking about rehabilitation, it's like learning new ways to cope with having dementia. And again, the video in the slide and information is on that slide there that I'm sure you can maybe put in the chat, Chris. And then next slide. And just last year, the 2 groups, also when we invited them to comment and contribute to our policy, our HP dementia policy, Connect, Build, Connect and Support, what they were saying to us as well. A number of us have had direct access to allied health professions. Their support, guidance and rehabilitation interventions have been invaluable to us, and we want to ensure that other people living with dementia, their families and carers also have access to their expert clinical experience, but we've still much to do. In summary, I've shared a multi-agency approach to integrate the rehabilitation evidence that we've heard about today into practice for the benefit of people living with lived experience in Scotland. All the work that I've mentioned and all the references are all available online if people are interested. And I guess I just want to finish that hopefully what I've done with my presentation is made you curious to find out more about how you can apply the evidence and the research into everyday practice. Thank you.
Elaine, thank you so much. Really, really great to hear about the work that's going on in Scotland and that complete integration into the NHS system. There was a super question in the Q&A, and Elaine, I'm wondering whether when you have a moment you could go into the Q&A and answer Kirsty's question, which was specifically about rehab in prison populations. Really interesting area. But I have a very quick follow-up question for you, Elaine, if that's all right. And Shita Singh in the Q&A said, in terms of the list that you put up, why is it the case that pharmacists are not included in the group of allied health professionals?
Fabulous question. Our government decides who's in the allied health profession community in the 4 nations in the United Kingdom. And so the list I put up in one of the slides, it's in the yellow. Pharmacy isn't included in that in my work programme. They're really important and they're key partners, particularly that contribution in sort of shop floor and people going into shops. So I'm not excluding you, it's just not part of my role and remit. And they're not included in our allied health profession family in Scotland, but they're a really important partner. And I would hope what they could do is host some of the resources we've got, Chris. So thank you.
Super, super. It'd be really interesting to see in the definitions, how that compares and contrasts with other countries as well. But look, as a panel, thank you so much for that. We're going to move into the proper Q&A section as well of this webinar. I've had lots and lots of questions coming in the Q&A box. If we can, I'm going to start with a really super question. And Jennifer, this is directed to you, but as a panel, please jump in and give me your thoughts as well. I thought this was a great question. Should rehabilitation be constant or intermittent? Jennifer, what are your thoughts?
Well, it depends what you mean by all that, doesn't it? As everything always does. Of course, it should be constant, but that could also be intermittent. You don't stop doing it, is the point that I'm making. You don't give up on someone, as I've found out, as I said before. It doesn't matter how advanced their dementia is. People lying in bed and they can still be rehabilitated. So, of course, it goes on forever, but you can't do it all the time, every day. So it is both.
Yeah, I was almost anticipating the answer there. Can I ask in terms of the kind of the research and maybe in terms of the practice, how does that fit, in terms of constant versus intermittent? How is it working at the moment?
You're asking someone else that, I presume.
Yeah, I'm opening it up to the panel. I was thinking maybe Alexandra or Yun-Hee from the research point of view, or Elaine, from the practice point of view. What's your experience with it?
Maybe I start with a general point of view where, unfortunately, and that is across health conditions, that is not only specific to dementia, this kind of information information on what is better or how much rehabilitation you need for a while or intermittent or continuously. Unfortunately, there's a lot of work to be done. Again, my perspective at the moment is in general. So this would include, to my knowledge, dementia, and actually a call for action for the researchers here in the call. But I pass the floor to Yun-Hee as being a researcher and doing fantastic work. So Yun-Hee, over to you.
Thank you. If you look at research evidence, researchers have to have time-bound intervention so that they can look at the outcomes often. And I've seen a program that lasts over 2 years. But often most of the rehab or reablement programs kind of last between a week to, 4 months period. And for example, our program, IHAB intervention, is offered over 4 months period. But that doesn't mean the person is actively working on every day awake moment. Depending on their goals, sometimes they need to actually practice their strategies every 2 second days, or sometimes they do it half an hour every day. And I guess just going back to earlier comment around intermittent and continuous intervention, it depends very much on their goal. And I feel that that is how it is delivered in practice, even though we have a time-bound concept. And if the person has achieved one goal, and they could look at another goal for the next, a month or so. So it very much depends on their goals and strategies.
Yun-Hee, it's triggered instantly an additional question, if I can, and Elaine, I'll come back to you on this one, but from Zhuang online, they thank you very much for the presentation, which was great, and they ask about aged care services, the ones that you mentioned in Australia. How are these adapted or applicable to young onset dementia? And I know that's going to be something that resonates around the world as well.
Yeah, so in Australia, for those people younger than 65 years old, and if they have dementia, they are under the scheme of a National Disability Insurance Scheme, NDIS. So under that NDIS scheme, they actually have more opportunity to have various types of allied health support services, whether they are framed as rehabilitation or not. But once the person passes the 65 years old, the opportunity is far less. I'm not saying that, you know, people with a younger onset dementia get rehabilitation access routinely. That's not the case. But under the scheme of disability, then people have more opportunity for rehab interventions.
Super. Elaine, it made me think as well that in my time in Scotland, the 65 age barrier was always evident as well. Pulling a couple of those strands together, maybe your thoughts on, you know, the rehabilitation as constant or intermittent in practice, and then what are your thoughts on that age barrier as well, you know, in terms of accessing for young onset?
I think when you asked that, I guess it made me think about, so when we talk about universal targeting and it's sort of individualised, that feels like it's a step on, step off. So particularly if you're, so the two examples I gave you around home-based memory rehabilitation and journey through dementia, for me, and when I've seen the occupational therapist deliver it, a lot of that's about actually supporting people to re-engage around community connectiveness. So, and then accessing and knowing when to access that rehabilitation, that specialist support that you need. So particularly with the journey through dementia, that's about re-engaging back in the community, whether from Third Sector Alzheimer Scotland or other organisations as well. Was the way is how we've approached it, and makes it accessible for people. For people with earlier onset, young onset, I do know when the therapists have delivered home-based memory rehab and journey through dementia, it's not age specific. So actually, it can be tailored because the principles that people have just spoken about in the research is about tailoring it and individualising it. So you would tailor and individualise what you're and listen to the person, what their goals are. So it has been applicable and it's worked with the younger population as well.
Actually, that's super to hear that the age barrier doesn't exist in this particular area. I know sometimes in health and social care integration that does become problematic, but in terms of accessing rehabilitation, I think that's a super strength in the system if it's already doing that. Jennifer, one request actually, it's not really a question as such, but a number of people I believe in the chat box are asking where they might be able to access the booklets and materials that you have produced.
Help!
I think you've gone back onto mute. Ah, you're struggling to hear us. Can you hear me now?
Sorry, that was our fire alarm gone off. Wasn't me.
Gosh, I hope you're okay.
Wasn't me. Anyway, thank you for that. Stephanie has managed to find the link and she's posted it in the chat.
Excellent. She's one step ahead of us. That's super that you're able to share them there.
So if people want to see that, it is there. She posted it at 2 o'clock.
Excellent. Now, let's move this conversation on because we do have lots and lots of questions. Alexandra, we have a question here that says, what needs to be done that all people with dementia in need of rehabilitation have access to it?
Yeah, which is actually the vision of WHO. And it's if we really talk about all people, this means globally. Of course, this is probably going to be a long process, taking into account that, as I mentioned in my presentation, the awareness is not there everywhere, and the knowledge about what rehabilitation is, and specifically how people with dementia can benefit from rehabilitation. So a first step would really be to raise awareness about that and to share information about what rehabilitation can do. Whether this is the WHO package of interventions for rehabilitation, or I saw in the chat, there are many other probably very, very fantastic resources, but it's about advocacy. The second thing that we know, and I'm also talking about, as WHO does, always having a more specific focus on low and middle resource context where the rehabilitation workforce is really often not there. So it also requires to strengthen the rehabilitation workforce. And as I said earlier, to also in the future train speech and language therapists, more occupational therapists, more psychologists specialized for rehabilitation. And we know that takes time. And until then, countries also can use a task sharing approach. So to train other health workers for some of the interventions to deliver those. I want to refer to one question that was about, but is it that we need to train the families and carers? I would not suggest to put more burden on families and carers. They do a lot, but of course we know they do a lot of care. And to train them, if they have the resources in some interventions, that would be a useful way to move forward. Last but not least, and probably this is also challenging, and I read one comment in the chat, I think that was from Austria, saying that because rehabilitation is only available for people with disability status, and people with dementia don't get disability certificates. So that means they have no chance to have access to rehabilitation. What we at WHO try to really more advocate for is rehabilitation is not only for people with disability, and people don't need to undergo a disability certification process. It's for people with health conditions. So it's for people with dementia. But this requires also advocacy in countries where this understanding is still not there. So a lot needs to be done, but we have good examples, not only for dementia, but for other health conditions. And we are optimistic that this is feasible, but I also have to say this is nothing that you can do until tomorrow. It will take time.
Yeah, I totally agree with you. I think the advocacy side is really, really important here, in terms of the awareness raising. It brings me right back to that thought right at the very beginning of this process about the burden being on the individual to seek it out and not the other way around. Yun-Hee, I'm going to come to you, and then I'm going to come back to a very interesting question about the role of GPs. Yun-Hee, please.
Oh, yes, I was just going to follow on the earlier question about the role of family carers and the support. In our trials, we deliberately work with family care as care partners. And what we learned was that the family members often have these preconceived ideas about how they best provide care. And often it's providing the care to the person, for the person, rather than working with the person. So in that regard, they really value the opportunity to learn about how they can work with their care recipient. And therefore, that also required some form of training in a way that they don't necessarily, try to do things for them when the person with dementia can do themselves. So there are many different steps, and that also ties back to those in low and middle income countries when there is not enough, specialists or allied health support services available. If you think about rehabilitation as a care philosophy, I think that's a really important step to address for those without any resources. When families and communities are actually able to understand that rehabilitation is actually working with the person, and the person's autonomy and sense of control is really important. I think this is where they could make some difference in the way that they experience dementia.
Super. Really, really good point. It brings me back to a couple of questions in the chat that relate to the role of doctors, specifically to GPs, general practitioners. And considering we have one on the panel as well, and then I'm going to come to Jennifer first. But the earlier part of that question was actually around GPs and doctors recognizing dementia earlier. But what is the role, or what should the role be in directing and referring for rehabilitation from the GP? Jennifer, I don't know if you have any thoughts on it from your time in practice.
Well, I have indeed. most doctors don't know that they don't know. And because I've got, as you probably saw, I've got my fellowship and that kind of thing, doctors are often prepared to come and listen to me, and I certainly let them know. And they all say afterwards, oh, we didn't know that we didn't know. So doctors need to be educated. They need to have it in their medical education. And I know I've forgotten her name, of course, the person in, oh, I can't remember her name, but she's in charge of the medical education for students. And she was very supportive of getting a lot of what I was saying put into the education, but she had to fight against all kinds of other people. So the first thing is that education's got to change. And then the GPs have got to tell the person with dementia it's not the end of the world, because so often, oh, I'm so sorry. You know, it's not. It's the beginning of a new life. It's a new opportunity. It can be jolly tough. Yes, I forget. I have hallucinations. The whole thing could be a mess. But I'm still going to smile. There's still life to live after dementia, and GPs can indicate that. And they can also help give indication to where resources are. I wasn't given any help when I had my diagnosis. Not a clue. GP didn't have a clue. So it's all back to education and informing the GPs, please.
Super. But on the broader panel, any thoughts, maybe from the research or even Elaine from the practice perspective, prior to it becoming occupational or allied health professional, how does it get to you? And is that a blockage at the moment?
Do you mean from primary care or people to know about us, Chris?
Yeah.
I mean, I guess what we've seen in Scotland is an opportunity, because actually primary care in Scotland's expanding and the workforce is expanding. So it's actually wider than just general practice. We've got physiotherapists in there, we've got occupational therapists, we've got paramedics, we've got advanced practice nurses. So there's something for me about awareness raising and an opportunity to work with that wider team, I think, as much as the GP is really important for the signposting. So I get, for me, Chris, what we've really done is actually looked at the opportunities for that workforce being in there, because actually if they can signpost to other support mechanisms or other information, and that's the approach that we've taken.
Yes.
As well as obviously the work that Jennifer's talking about is education for the students.
Great. Look, I'm going to ask one more specific question from the Q&A and keep it open for the panel. And then I'm going to come back to you for your final thoughts before we close, because we've only got a few minutes left. It's a super final question, I think. And is there a place for remote care and telecare in rehab interventions? And I'm not sure who the question came from, but they flagged that face-to-face interventions are obviously preferred, but sometimes limited. In terms of the research and the practice side, what's the current situation with remote care and telecare?
May I start?
Yes, please. Yeah.
Yeah. So there have been some studies looking at the delivery of rehab or reablement program by telehealth, and the studies. One of them is led by Professor Kate Laver, and she looked at the use of COPE, which is a reablement program that I mentioned earlier, that was developed and tested by Laura Gitlin's team in the US. So they successfully delivered the COPE program by telehealth, which is COPE program is multidisciplinary but largely led by occupational therapists. Our program also has, so IHA program that I mentioned earlier now is being tested in residential care home as iCHOP, interdisciplinary care home based reablement program. We had to offer a telehealth mode for care homes in rural regional areas in New South Wales. And lots of challenges at the beginning, but actually we saw a great deal of positive outcomes. And it is about how teams are able to communicate with each other and they could actually work together. But telehealth requires in rehabilitation, in probably other programs in care home settings, you do need the additional person to be with the person with dementia. And therefore, there is the facilitation between the person and the therapist via Zoom or other telehealth mode. But it actually works. And we saw a lot of positive outcomes.
Super, super. Look, I know we, as always with these sessions, we could go on for another hour, but we have 30 seconds left. So, Alexandra, I'm just going to ask you as our final panelist contribution, mainly because of the overarching strategic vision from WHO, where would you like to see dementia-related rehabilitation in 5 years' time?
So, to be realistic, I would like to provide a realistic scenario. It's not in 5 years. It will not be the case that everyone will have access to rehabilitation. But we would be very happy if, on the one hand, more countries included rehabilitation in benefit packages. And it's again what I also said, also to have the rehabilitation workforce that I've mentioned, including nurses. And there were so many important comments, social workers and general practitioners, to be more aware, because that is really the starting point, that people are informed about the benefits of rehabilitation. And I think if this would be the case in more countries, in about 5 years, we would have achieved a lot.
Yeah, it would be a big step forward. Look, I think we've all got a role to play in this. We are completely out of time. I want to thank the panel for what has been a truly exceptional webinar today. I'm so glad we've done this. To reiterate, this is the beginning of a year of focus on rehabilitation from ADI and all of our partners, building up to the World Alzheimer Report in September. Thank you all for joining us. We will make this available as a recording. Please do circulate it amongst your friends. We will email that out to you and share it on the social media channels in the next 24 hours. So thank you once again. Please enjoy the rest of your day and your evenings. Goodbye.